Hi, I'm Denise. I'm a third-year medicine resident,
I'm Charlie, a third-year Med Peds resident.
and today we are going to be talking about tachycardia and what to do when you get that phone call in the middle of the night as a freshly minted intern that a patient is tachycardic. So we're going to be going through a stepwise algorithm approach about this sort of scenario. When the nurse calls you that a patient is tachycardic, you want to, pretty much immediately ask what are the other vitals? What is the blood pressure? What's the respiratory rate? What is their temperature doing? We always ask for a fresh set of vitals when the nurses are calling you about this sort of scenario. So now that you know what the vitals are, number two is, are they stable or are they unstable? If the patient is unstable, you pretty much want to assess them immediately as you're talking to the nurse on the phone. Just, pick up your stethoscope and just head on over to find the patient and, assess them immediately. At that time, you also want to reach out to your CCU and or MICU seniors. Let them know, hey, there's someone that's potentially not doing well on the floor. I need some backup. And that's one thing that we want to bring to you guys' attention is that you are never alone in the hospital. There's always somebody there that can help you. We are a team at the end of the day. So you should never have to feel that you're alone. Always ask for help from your CCU or MICU seniors. And then, start thinking about potentially emergency interventions that you may require based on what the RNs have told you. Stat fluid boluses, type and cross, whatever the case may be. Now, if they're stable, you have a little bit more time. You can chart review really quickly, see see why they've been in the hospital, what's been going on with the patient during their hospitalization. Look at their vitals trend. Have they been tachy for the last 24 hours, and this is something that's chronic, or is this new that just happened in the last 15 minutes or so? And then as you're going through the chart and you've gotten your basic info from the nurse, you want to start thinking about potentially building a differential diagnosis. One thing that you should always ask the nursing staff to get pretty much right off the get-go is always ask for an EKG to be able to see, if they're potentially in some sort of arrhythmia or this is a sinus tach or, whatever the case may be. But always ask for an EKG, and then always ask for a point of care glucose. There have been so many times when, there's all this stuff going on, you're caught up in the moment, and then you realize, oh wow, their blood sugar was actually 55. So it's a very quick thing that the nurses can do for you while you're getting there to see the patient is getting the EKG and getting a point of care glucose check.
All right, so as you're going through and you're getting your EKG, you're getting your glucose, you're done your chart review, you consider like the differential, right? So you're going to be breaking this up or an easy way to break it up is primary versus secondary causes. You can see our differential over here kind of gives you a list of things. And so when you're thinking primary, you're thinking something like within the heart itself or like surrounding right around it. Whereas secondary is going to be something that the heart is actually functioning normally, but is trying to compensate for a problem somewhere else in the body. Now, this differential list doesn't list everything possible, but it's some of the most common things that you'll see. For us, definitely one of the things you're going to see is volume, so like volume depletion. Why is the patient depleted? Is this an issue with anemia? Have they had any recent surgeries, any recent injuries? Are you worried about a GI bleed? Is it secondary to sepsis? Is this a patient that, chart review has been admitted for fevers? Did they give you fevers initially? Do you have any reason to think that they're at risk for like central line infections, things like that? Next, going over to like our primary causes, and again, hopefully something that you might have been able to differentiate with your EKG, is this a patient with an arrhythmia? Again, if they're really tachycardic, it can be really difficult to tell, is this a patient AFib? Are you able to see P waves? It can be difficult to tell, but the EKG at least will sometimes allow you to rule out an arrhythmia. Going back to your vitals, if you do have hypoxia, is this a patient that has a history of clots or is high risk? Are they immobile? Something you can consider is your like lung-based problems in a PE. That's something that can be life-threatening, something that you want to rule out early on. And then once you've kind of gone through these, which are going to be some of your more common ones, specifically with like volume loss, consider, is this a toxin or drug issue? Is this something that we've given the patient that we've iatrogenically caused? Or since the patient's normal daily schedule's kind of been messed up, you don't know what they were doing prior to admission, are they withdrawing from it? And then something that we also commonly see is this a patient that's in a lot of pain. A lot of times, discomfort, whether they recently had a surgery. Is this a patient that has chronic pain and that we haven't started all their home meds, or something that else recently happened, motor vehicle accidents? There's a whole host of reasons to be in pain. But that's going to be one of the most common causes that you see. Whenever you're going to see the patient, after you've already kind of built the differential in your head, you're going to go through your exam. And it's important to have a stepwise fashion where you go through every different system, try to do the same thing every single time you see a patient, and that'll allow you not to miss anything. Starting out, part of the exam is going to be subjectively talking to them. Are they alert and oriented? Are they mentating? If not, that kind of moves you more towards your unstable pathway. Then going from there, listening to the heart. Is this something? Are you able to hear that the heart rate's irregular? Listening to the lungs. Do you hear fluid overload? Do you hear any crackles? Does that kind of point you towards a pneumonia? Is their abdomen distended? That can cause pain. That could also be like a abdominal bleed or something like that if they're post-surgery. So it kind of can be the pain section. It can be the volume section. And then looking at the lower extremities, are they fluid overloaded? Are you concerned about heart failure, renal failure? Do they have asymmetry between one side or the other? That would point you more towards like a DVT and then possibly even a pulmonary embolism. Going through a good physical exam, inspecting the skin, talking to the patient, letting them tell you what's hurting, what's not, that will give you a great idea of which of your differential is more likely versus less likely. And then once you've built your differential, that's when you start going through your different treatments. Again, that's when you start talking to your seniors. You're never alone. A lot of times you'll be working side by side with them. Communicate with them. You're not bothering them. And that can help you decide which plans I need to do. If they're unstable, it'll get them to the ICU quicker, which is important because the time and how long that takes is important. And then doing all those things will kind of help you not miss anything that's going to have a negative impact on the patient.
So to summarize, what we want you guys to get out of this video is 1, always ask for the remaining vitals. 2, get an EKG and point of care glucose check. And then 3, talk to your seniors if necessary about this.